Hello, my name is Nat Jones and I'm a clinical academic occupational therapist. The focus of this presentation is co-designing an implementation toolkit for breakfast group interventions in stroke rehabilitation, how patients and informal carers shape the end product. This presentation is based on an aspect of my PhD study, breakfast group interventions in stroke rehabilitation, BISTRo for short. There are no conflicts of interest, and any references on the slides can be found on the final slide. So the aims of this presentation are to gain an understanding of how experience-based co-design can be used to collaboratively develop resources that are acceptable for patients and feasible for occupational therapists to use in breakfast group interventions. I'd also like to share with you how experience-based co-design can facilitate the creation of patient-centered resources. So, what are breakfast group interventions? They are multidisciplinary interventions to support people with eating and drinking difficulties in inpatient stroke rehabilitation wards. Breakfast groups bring together stroke survivors Monday to Friday for approximately an hour to an hour and a half to make their own breakfast and eat with one another in a social dining context. The idea for this study came from some earlier research I did looking at the lived experience of stroke survivors 6 months after discharge from hospital, and this was published in the British Journal of OT. So what is co-design? Well, co-design in healthcare has been evolving incrementally over the last 20 years, and healthcare has borrowed the principles of co-design from other sectors, such as the design industries, architecture, engineering, product and software design. This definition by Goodrich in 2018 nicely describes the collaborative approach of bringing patients together with staff to design services or products that meet the end user's need. Glenn Robert and Paul Bate have widely published on this methodology of co-design in healthcare, and if you want to find out more, there are some references at the end of the presentation. So I wanted to also debunk a little bit of terminology around this. I've added 2 further definitions, one for co-production and one for co-creation. Together with co-design, these terms have been used collectively to describe a number of approaches, and it's called co-approaches. So the way I think about these terms is if I was thinking about my study, I'm thinking about working with stroke survivors, formal and informal carers to co-produce an intervention and toolkit, and together we will co-produce a prototype which will be iteratively tested in 3 stroke wards. Together we will co-create new knowledge by using participatory research methods to understand the problems encountered by stroke survivors and generate ideas on how to solve problems and collaborate together, and we'll be applying our co-created knowledge to co-design a breakfast intervention and supporting toolkit. So this leads me on to think about experience-based co-design. So I have chosen this method, which is based on it's got an evidence base and it's been used as a service improvement methodology, but latterly it's been used as a participatory research method. It was first described in a toolkit published by the King's Fund in 2006, and it's now housed at the Point of Care Foundation, and there's a website for you to check out. The most recent guidance on how to develop complex interventions by O'Cathan et al. In 2019 references 9 approaches to intervention development. And experience-based co-design is one of those approaches. It's under the partnership approaches. So partnership approaches are defined as involving the people who the intervention is aimed at in helping you to make decisions about the intervention and throughout the development process. Partnership approaches have this ethos of equal decision-making powers and everyone having a voice and stakeholders being part of the research team. So if you want to know more about experience-based co-design and have access to the free toolkit from the Point of Care Foundation, check out the link on the slide. So what are the principles of experience-based co-design? Well, they are a focus on lived experience and seeking to understand the stories and narratives of people who are in the service or receiving the service. A deep dive into experience through observation and analysis, and everyone participating in the process of generating new ideas. It's an equal power sharing approach. So how do we include patients, formal and informal carers in co-design? Well, there are many ways, and I'm sure you've got other ideas, and if you can put them in the chat, it would be great to hear. The methods that I chose are consultation, public and patient engagement, interviews, ethnographic observations, and films. So experience-based co-design is a 6-stage method. And what I'm going to do now is talk through that stage with you in relation to my study. So the first stage is stakeholders. I recruited 15 stakeholders, and you can see who they are on the slide. And my main aim was to have a mixture of patients, informal carers, and formal carers, so NHS staff. I also collaborated with a patient in public involvement group who were already established with 10 stroke survivor members. The PPI group met for 3 times during the intervention design phase, and the stakeholders met for 10 workshops over a 4-month period. So this engagement with staff and patients and informal carers took the form of interviews, consultations, and ethnographic observations. I also created something called a trigger film, or several trigger films. Now, trigger films are a central part of experience-based co-design methodology. Traditionally, trigger films were used in service improvement to make everyone aware of the patient's experience. So recording patients talking about their experiences to stimulate discussion between patients and staff around service delivery issues. And this is how I use them in my study. The films were co-designed with patients, carers, and NHS staff. And I recorded 8 videos and edited those down into 3 trigger films, which were used to trigger memories, create ideas, provide emotional touch points for the stakeholders to engage with particular topics. And I've got a reference at the end of the slide where you can learn more about trigger films. So stage 4 and 5 involve stakeholders coming together to iteratively develop the intervention and the toolkit. So as a result of COVID, the workshops were taken online, which did add a layer of complexity to proceedings. The group set about establishing their own ground rules for collaboration. We used the National Institute for Health Research Principles for Co-Production in Research as a reference point for those ground rules. I generally set the agenda of work and prepared papers and circulated them before the meetings in multiple forms for accessibility. Technology wasn't always our best friend, so we did have, quite a bit of time at the beginning of meetings trying to figure out and get everyone into the meeting. But sessions were recorded, which made facilitating easier for me, and I was able to capture the rich discussions in the group. And in between meetings, I wrote up the key points, circulated them, and invited feedback. And we did that through a number of methods, such as by phone, email, or WhatsApp. And during the co-design activities, we used a range of different platforms and tools to collaborate, but not everyone could use those, and it wasn't always easy. So sometimes we just reverted to general discussion and brainstorming sessions. So we used information from the stages 3 and 4 to inform our discussions, as well as key themes from a systematic review that I conducted on the psychosocial impact of eating difficulties. So a quick plug here for my poster, P38, go and check it out. So the first prototype was tested in Site 1 for 10 breakfast group sessions, and feedback was collected in the form of brainstorming and notes and logbooks. And so I collected all that feedback in and verbal feedback, and then we developed a version 2 prototype with the stakeholder group. And this was tested in Site 2 and Site 3. Feasibility and acceptability of the intervention was explored through 12 patient interviews and 3 focus groups. So at the end of all this, after the analysis, we came together to celebrate the study. And I brought together a whole collection of people into an open research event. And this was an opportunity to disseminate findings, to discuss implications for practice. And I've also added in an additional stage to experience-based co-design, which I've called dissemination, knowledge mobilization, and impact. And here we, in the open research event, we explored what we had learnt, what the impacts of the research were, and how we could mobilize now this knowledge into practice and sustain breakfast group interventions. I also used an impact research tool, which I have published, and the links are on the slide, to capture the softer byproducts of research and those impacts that are specific to service improvement. So I now want to share with you some powerful narratives and how these influenced the development of the resources and the intervention. So here is a mind map. I use mind maps a lot. Mind maps were used to analyze the field notes from the ethnographic observations. And this branch of the mind map shows you how the things that were important to patients were drawn out to influence the co-design of the intervention itself. I also use the powerful narratives to inform the design process when I did some in-depth interviews, and I shared the findings from these interviews with the stakeholder group. And you can see how the findings suggest the negative emotions that people were influencing, but also the importance of eating and drinking difficulties. And these were discussed at length in the stakeholder group. The power of narrative was so important in the 8 videos. These trigger films were used to tell stories, which created lots of passionate discussion about difficulties that people experience and how we need to tailor the intervention to address those difficulties. So I'd now like to share with you some of the components of the toolkit which were co-designed. So first of all, there was a training manual and resources for staff on how to deliver the intervention. We had a lot of aphasia-friendly resources, including things like aphasia-friendly menus. We also developed a patient booklet for treatment planning and goals and recording the daily sessions. We also developed a personalized assessment booklet, which was a conversational tool, and specific outcome measures for this intervention, and lots of other products in the toolkit, such as personalised place name settings, which held vital information on the underside to prevent patients being asked multiple times the same question. So here are a few photographs of the breakfast group in action. I was walking one gentleman to his room one day after group, and he leaned in and whispered in my ear, "This is the best hour of my day." And you can see what the patients were getting up to in the group. So here are a few takeaway points. Co-approachers have provided valuable insights for designing the breakfast group intervention, and stroke survivors were very much at the heart of this research, designing the intervention to meet their needs. Mixed methods research has helped me discover rich perspectives and explore the phenomena of eating and drinking difficulties from different perspectives. And a focus on lived experience of stroke survivors and the end user to the intervention has really ensured that we've developed something that is acceptable and feasible for staff and patients. So thank you for listening. I'm happy to take any questions. I'd just like to thank the funders for my project, the National Institute for Health Research, and also thank my academic supervisors, Professor Sue Mawson, Alicia O'Cathan, and Avril Drummond. Thank you very much.